Now we are going to start intestinal obstruction. So first, what is the most common cause of large bowel obstruction? And the most common cause is malignancy. Most common cause of small bowel obstruction, that is adhesions. So most common cause of large bowel obstruction, that is malignancy. It is malignancy. And most common cause of small bowel obstruction, it is adhesions. So you have to read the question carefully, right? Small bowel obstruction, it is adhesions. So in detail, we are going to discuss small bowel obstruction. Here we discuss the most common cause, it is adhesions. After adhesions, the second most common cause is malignancy, then hernia, then Crohn's disease. So it is adhesions followed by MHC. How to remember? It is adhesions followed by MHC. Okay. What is the cause of adhesions? Adhesion is because of previous surgery. So in which kind of surgery there is maximum risk of adhesive intestinal obstruction? So in pelvic surgery there is maximum risk, followed by lower abdominal surgery, followed by upper abdominal surgery. So in which cases there is maximum risk of adhesive intestinal obstruction? Adhesive small bowel obstruction. There is maximum risk in which surgery? Maximum risk in pelvic surgery, followed by lower abdominal surgery, pelvic, followed by lower abdominal surgery, followed by upper abdominal surgery. Upper abdominal surgery. So sometimes in exam they give you options or examples, like suppose they are giving the example hysterectomy, appendectomy, cholecystectomy. Which one is having maximum risk of adhesive intestinal obstruction? So obviously hysterectomy is a pelvic surgery, appendectomy lower abdominal surgery, and cholecystectomy upper abdominal surgery. So these are the format of questions which are being asked. Imagine this is the bowel, this is a small bowel, this is the jejunum. So imagine here is the obstruction. The moment patient is going to sense the obstruction, what will happen? There is hyperperistalsis. Because of that, there is colicky pain. Patient will be having multiple episodes of bilious vomiting, and there is non-passage of feces and flatus. That is known as absolute constipation, also known as obstipation. Out of these, which one is the most common symptom? It's the colicky pain. The most common symptom, this is colicky abdominal pain. There is bilious vomiting, non-passage of feces and flatus. Whenever there is hyperperistalsis, if you're going to auscultate the abdomen, there is hyperactive bowel sound. So initially for first 4 to 6 hours, there is hyperactive bowel sound, and later there is sluggish bowel sound. Second important point, whenever there is obstruction, what will happen? The proximal part of bowel, it will be distended, and the distal part of bowel, it will be collapsed. So in proximal part of bowel, there will be collection of what? Whatever the food and fluid patient has taken. Second, there will be secretion from the jejunum. So what will happen? There is secretion from the jejunum. Another important point, imagine a patient who is having duodenal obstruction, means in proximal obstruction, which symptom is more prominent? Vomiting. And if a patient is having ileal obstruction, which symptom is more prominent? Distension. So vomiting and dyselectrolytemia, it is more prominent in proximal obstruction. Distension, it is more prominent in distal obstruction. So vomiting as well as dyselectrolytemia. So vomiting and dyselectrolytemia. Because of vomiting, there is dyselectrolytemia. So vomiting and dyselectrolytemia, it is more common in proximal obstruction, and distension is more prominent in distal obstruction. So in distal obstruction, there is distension, which is more prominent. Distension. Now another problem, in the proximal part, what happens? There is collection of food patient has taken, fluid as well as secretion from jejunum. So what happens? These patients are also going to develop what? Hypovolemia. Hypovolemia. And for formation of air fluid levels, is the swallowed air which is responsible for formation of air fluid level. So in swallowed air, what is the major component? There is nitrogen. So these are important points. So at the time of presentation, when patient is brought to your emergency, patient is unstable in majority of cases. Why? Because patient is having hypovolemia. So because of this hypovolemia, patient is having tachycardia and there is hypotension. So whenever these patients are brought to your emergency, first what we have to go for? First we have to go for the fluid resuscitation. So in all these patients, we have to give or go for fluid resuscitation. And the fluid of choice here, what is the fluid of choice? It is Ringer lactate. So fluid of choice in these patients, it's the Ringer lactate. Apart from fluid resuscitation, we have to perform proximal decompression. And how you perform proximal decompression? You have to insert the Ryle's tube. So Ryle's tube insertion for proximal decompression. And what else we have to do? We have to perform Foley's catheterization. What? We have to perform Foley's catheterization. Why? For monitoring of urine output. Why? Because you know what is the best clinical indicator of tissue perfusion? Best clinical indicator of tissue perfusion, that is urine output. It's the urine output which is the best clinical indicator of tissue perfusion. And after adequate tissue perfusion, how much should be the minimum urine output? In adults, after adequate tissue perfusion, how much should be the urine output in adults? It is 1 ml per minute. This is 1 ml per minute. And in children, how much should be the urine output? This is 0.5 to 1 ml per minute. 0.5 to 1 ml per minute. Clear? We can convert it into ml per hour. So here you can see 1 ml per minute means how much? It's 60 ml per hour. Sometimes in exams, they ask you ml per kg per hour. So how much? It is same 1 ml per kg per hour. Imagine an adult patient, the reference weight is 60 kg. So how much per hour? Obviously 60 ml per hour. So you have to remember both. In adults, it is 1 ml per minute. In children, 0.5 to 1 ml per minute. Or you can remember it 1 ml per kg per hour. This is the urine output after adequate tissue perfusion. So whenever patient is having adequate tissue perfusion, then only we are sending the patient for investigation. And what is the investigation of choice for diagnosis of small bowel obstruction? We go for X-ray abdomen. Investigation of choice for diagnosis of small bowel obstruction. This is X-ray abdomen, and there are two views which we are going to perform, erect and supine. We perform erect as well as supine, and you know that erect view, it is better for air fluid levels. Supine view, it is better for site of obstruction. And if you have to choose one, which one we are going to choose? Supine is better than erect. Now, what are the roles of CT in small bowel obstruction? If a patient is having high grade obstruction, there are extraluminal causes, means the obstruction causes outside the lumen which cannot be detected easily. So for that we go for CT. And if patient is having complication like strangulation, so in all these cases we go for CCT. There is another investigation, enteroclysis, also known as small bowel enema. So another investigation, it is enteroclysis, also known as small bowel enema, and this is investigation of choice for LISBO. How to remember? This is LISBO. So full form, mnemonic is LISBO. Low grade, L means it is low grade, I means intermittent. So this is low grade intermittent small bowel obstruction. So it is LISBO. Low grade intermittent small bowel obstruction. For this we go for enteroclysis, that is known as small bowel enema. So in small bowel obstruction there are multiple bowel loops. And what is the location? Placed centrally, and these are narrow in caliber. Placed centrally, these are narrow in caliber. Special feature of jejunum, in this case you can see there is circumferential ring-like pattern, and this circumferential ring-like pattern, this is known as valvulae conniventis. So this is a special feature of jejunum. What is the name? This is known as valvulae. This is known as valvulae conniventis, circumferential ring-like pattern, and this is seen in jejunum. Characteristic feature of jejunum, ileum is featureless or characteristically characterless. So this is supine view, and in upright posture you can see what? This is air fluid levels in step ladder pattern. Air fluid levels in step ladder pattern. In this image you can see this is the bowel loop which is wider in caliber. Can you see? Placed peripherally, wider in caliber, and there is presence of what? Hostrations. So these are what? These are hostrations. So how to identify large bowel obstruction? First, it is placed peripherally. So this is placed peripherally. This is wider in caliber, placed peripherally. It is wider in caliber, and another special feature that there is presence of what? Hostrations. Presence of hostrations. Clear? So this is what large bowel obstruction. And obviously here you can see on upright view, you can see that there is step ladder pattern. Dilated bowel loops in step ladder pattern. So this is how you can easily identify whether it is small bowel obstruction or large bowel obstruction. Now the treatment depends on the cause. So in cases of adhesions, we go for adhesiolysis. So if patient is having adhesions, we go for adhesiolysis. If patient is having malignancy, we go for resection and anastomosis. So resection and anastomosis. Patient is having hernia. In that case, we go for reduction. For hernia, we go for reduction. And for Crohn's disease, again, what we go for? Resection and anastomosis. So these are treatment options for small bowel obstruction. What is post-operative ileus? So after surgery, there is failure of neuromuscular transmission in the bowel. This is post-operative ileus. That's why you have seen in the ward that after surgery, we insert the Ryle's tube until patient is having presence of bowel sound. So now see, in which of the following organ earliest disease activity is seen? So in small intestine, earliest disease activity is seen and it is seen within 24 hours. So earliest disease activity in small intestine, it is seen within 24 hours. In how much time the activity is seen in stomach? Within 48 hours. 48 hours. And colon takes how much time? 3 to 5 days. So colon takes 3 to 5 days. Another important point, in small intestine, in which particular organ earliest activity is seen? In duodenum, jejunum or ileum. So in small intestine, it's the jejunum. And in jejunum, the activity is seen within 8 hours. In jejunum, activity, it is seen within 8 hours. It's a question. So earliest disease activity, it is seen in jejunum within 8 hours. So here you can see which organ is responsible for post-operative ileus. So you can see here that in colon, it takes 3 to 5 days for activity. That's why for post-operative ileus is the colon which is responsible. In this image, you can see that there is telescoping of one segment of bowel into another. And this telescoping of one segment of bowel into another, this is known as what? This is known as intussusception. And here you can see ileum is going into colon. Since ileum is entering into colon, so what is this type? This is ileocolic. And this ileocolic type of intussusception, it is the most common type in children. So important points you can see here. Intussusception, it is telescoping of one segment of bowel into another. It is more common in children. In which particular age group? More common in children. Age group 4 to 10 months of age. 4 to 10 months of age. Most common type we discussed. The most common type, ileum goes into colon. So that is ileocolic. And the most common type in adults, that is colocolic. In adults, it is colocolic. In this image, you can see the images. What? There is intussuscipiens. So, recipient is intussuscipiens. Recipient means the part of intussusception which is accepting. Clear? So, intussuscipiens, it is receiving segment. So, intussuscipiens, it is the recipient. And incoming segment, that is known as intussusceptum. So, intussusceptum, this is incoming segment. And intussuscipiens, how to remember? Intussuscipiens is recipient. So recipient is suscipiens. That is recipient. Third, where it enters into bowel, this part is known as neck, and the terminal part, it is known as apex. Here you can see this terminal part, this is known as apex. So one important question which is asked, that which part is most prone to gangrene? In intussusception, which part is most prone to gangrene? So you can see here, it's the apex. Apex is most prone to gangrene. So it's the apex which is most prone to gangrene. There are some of the anatomical abnormalities which are going to initiate the intussusception, and that is known as what? Lead point. So lead point is the leader which initiates the intussusception. And what is the most common lead point? This is Meckel's diverticulum, followed by polyp. It's a question. So most common lead point for intussusception, Meckel's diverticulum followed by polyp. Sometimes tumors are also responsible for intussusception. So what is the most common tumor responsible for intussusception in children? It is lymphoma. And you know that lymphoma is the most common small bowel tumor in children. So most common tumor responsible for intussusception in children, it is lymphoma. it is lymphoma. And in adults, this is villous adenoma. In adults, it is villous adenoma. It is villous adenoma. So here we discussed what is the most common type. It is more common in children, and the most common type, it is ileocolic. Since ileocolic type is the most common, patient will present with small bowel obstruction. Patient will present with signs and symptoms of small bowel obstruction. Patient is child of 4 to 10 months. So mother is going to describe the complaint that, sir, at the time of attack, child pulls legs towards abdomen, cries a lot. There are multiple episodes of vomiting. So these are signs and symptoms of colicky pain. Multiple episodes of vomiting means small bowel obstruction. What kind of vomiting? Bilious vomiting. Clear? Third, she is going to tell you that in between attacks, child is normal, means asymptomatic. What happens? Imagine there is attack, this part of bowel is entering here. When it comes out, child becomes asymptomatic. So in between attacks, child is asymptomatic. Another symptom which mother is going to give you, that whenever there are 3 to 4 attacks, child is going to pass little amount of stool mixed with blood. And what is the name of this appearance? What is the color? This is having red currant jelly appearance. So there is red currant jelly appearance. What is this red currant jelly? After multiple attacks of intussusception, there is passage of small amount of stool mixed with blood having red currant jelly appearance. In this image, you can see this is the kind of intussusception. So what happens? There will be sausage shaped mass, and where is the mass? In the right lumbar region. And if you are going to examine this right iliac fossa, this is empty. So what are the findings here? There is sausage shaped mass. What happens? These patients are having sausage shaped mass. And where is this sausage shaped mass? In the right lumbar region. And you can see here that there is empty right iliac fossa. This is empty right iliac fossa. And you know what is the name of this sign? This is known as sign of dance. Empty right iliac fossa, that is known as sign of dance. Clear? What is the investigation which is both diagnostic and therapeutic? It is enema. So if you give enema, what happens? The bowel loop comes out. So which enema is preferred? Air enema is preferred over barium enema. The investigation which is both diagnostic and therapeutic, this is enema. And we discussed which enema. Air enema is preferred over barium enema. So here, air enema, it is preferred over barium enema. Air enema, it is preferred over barium enema. Clear? Now imagine a patient is having intussusception and you have given air enema, patient was improved, patient was discharged. Again there is an attack. So if there is recurrence, again we have to give air enema. So which recurrence is an indication for surgery? Is the third recurrence which is an indication for surgery. So we discussed this is the air enema which is both diagnostic and therapeutic. For recurrence, repeat air enema. For recurrence, we have to repeat air enema. And third recurrence, this is an indication for surgery. So it's the third recurrence, you have to remember. Third recurrence, this is an indication for surgery. Clear? And which kind of surgery is done? Yes, the part of bowel which is involved in intussusception, we are supposed to excise it. So which part? You can see in this image. Here you can see, this is the part of transverse colon. This part of ileum is entering. So what I'm going for? I'm going for ileocolectomy. And after performing ileocolectomy, this ileum is anastomosed to transverse colon. So this kind of anastomosis is ileotransverse anastomosis. So what is the surgery? Name of surgery which is done? Name of surgery, we perform ileocolectomy. This is ileocolectomy plus ileotransverse anastomosis. This is ileocolectomy plus ileotransverse anastomosis which is done. Two important radiological signs which are seen on barium enema. These are frequently asked in the form of image-based question. So here you can see this loop of bowel entered here and this is a type of intussusception. So you can see what is the name of this sign. This is known as claw sign. So this kind of appearance is there. Name of this sign, it is claw sign. Here you can see one loop of bowel entered into another. So this kind of appearance, this is known as what? Coiled spring sign. So two important image-based questions. One, claw sign, and second is coiled spring sign, which is seen in intussusception. Apart from that, on ultrasound, there is pseudo kidney sign, there is target sign. idiopathic colonic pseudo-obstruction in which there is no actual obstruction, that is known as Ogilvie syndrome. So what is the name of idiopathic colonic pseudo-obstruction? That is Ogilvie syndrome. In colonic pseudo-obstruction, there is sympathetic overactivity. That's why which drug we give in the treatment? Parasympathomimetic. And what is the drug of choice? You have to remember, this is neostigmine. So we have to give what? Neostigmine. That is the drug of choice. It's a frequently asked question. So this is neostigmine and usually given IV. So neostigmine, that's the drug of choice. It's given IV. It is parasympathomimetic. What is the most common cause of large bowel obstruction? We discussed it is malignancy. Most common cause of large bowel obstruction, that is malignancy. And what is the most common site of large bowel malignancy? You know, it is rectum. This is rectum followed by sigmoid. So most common site, this is rectum followed by sigmoid. See, adhesions are rarely responsible for large bowel obstruction. So in small bowel obstruction, there is colicky pain, multiple episodes of bilious vomiting, and non-passage of feces and flatus. Here, at the place of bilious vomiting, the patients will be having what? Abdominal distension. Here, since the malignancy is in rectum or sigmoid, it develops from hindgut. That's why pain is not in periumbilical region. Here, pain is in the hypogastrium or in the lower abdomen. So clinical features, colicky pain in the lower abdomen. Where exactly? It is in the hypogastrium. So there is colicky pain in the hypogastrium. These patients have abdominal distension and there is non-passage of feces and flatus. That is obstipation, also known as absolute constipation. So conservative management protocol means resuscitation protocol. It is similar to small bowel obstruction. When the patient is brought to your emergency, you resuscitate the patient, put the Ryle's tube, insert the Foley's catheter, and whenever urine output is 1 ml per minute, then send the patient for investigation. And here also, investigation of choice for diagnosis is same, X-ray abdomen. But the management is different. Why? Because most common cause is malignancy. So what management protocol we are going to follow here? Since it's malignancy, we perform resection and anastomosis. And you know that in GIT, how much margin we take? During resection and anastomosis, we take 5 centimeter margin. Now imagine this is the patient. Where is the malignancy? Malignancy is in the sigmoid. Imagine this is the patient and malignancy is in the sigmoid. You can see what is this valve? This is IC valve. So there is unidirectional movement at IC valve. Means here there is no option of proximal decompression. So what kind of obstruction is there in large bowel obstruction? It is a type of closed loop obstruction. What kind of obstruction? It is a type of closed loop obstruction. So large bowel obstruction is a real emergency. First important point. Second, how to differentiate whether patient is having small bowel obstruction or large bowel obstruction during surgery. Whenever we are going to open the abdomen, what we have to check? We have to check the cecum. Imagine any patient who is having this small bowel obstruction. So obviously obstruction will somewhere in the small bowel, duodenum, jejunum, ileum. So what will happen in that case? Cecum will be collapsed. And if patient is having large bowel obstruction, obviously the obstruction will be beyond cecum. And whenever obstruction will be beyond cecum, cecum will be distended. So first structure you have to see is cecum. If it is collapsed, it means patient is having small bowel obstruction. If it is distended, it means patient is having large bowel obstruction. Now, what should be the treatment for right colonic malignancy? Obviously, we go for resection. Anywhere in the right colon malignancy is there, you go for resection. And after resection, what? This is the ileum and this is the part of transverse colon. So you perform anastomosis between ileum and transverse colon. So this is what? Iliotransverse anastomosis. So what kind of surgery is done? Yes, resection. And after resection can be, usually it is right hemicolectomy or extended right hemicolectomy. So resection plus iliotransverse anastomosis. This is resection plus iliotransverse anastomosis. Second situation, imagine patient is having left colonic malignancy and most commonly it is located in which part of left colon? Yes, sigmoid. So for sigmoid we have three options. Either we can go for sigmoidectomy. And if we perform sigmoidectomy, we perform anastomosis between colon and rectum. So sigmoidectomy with colorectal anastomosis. Some patients are going to present late. And if patient comes late, what happens? These patients are having massive colonic distension. And if this patient is having massive colonic distension, if the colon is papery thin, totally ischemic, so in this case, I can go for total colectomy. And if I go for total colectomy, what option we have? I go for ileorectal anastomosis. So second option, we can go for total colectomy plus ileorectal anastomosis. So for sigmoid malignancies, first option, we can go for what? Sigmoidectomy. And after sigmoidectomy, what we can go for? Colorectal anastomosis. So this is colorectal anastomosis. Second option, we can go for total colectomy. And if we perform total colectomy, what kind of anastomosis is done? This is ileorectal. So plus ileorectal anastomosis. And third option which we have, that's Hartmann's procedure. The third option which we have, that's Hartmann's procedure. So what are the components of Hartmann's procedure and in which patients we go for Hartmann's procedure? Now imagine this patient. This patient is having sigmoid malignancy. What is the age of this patient? Age is 60 or 60 plus. In such cases, after sigmoidectomy, if you're going to perform the anastomosis, there are risk of anastomotic leak because in elderly patient, there is atherosclerosis. So what happens? Because of atherosclerosis, there is poor blood supply at the site of anastomosis. So we don't take risk here. What we perform sigmoidectomy, and what we do, we take out this descending colon out. So we perform descending colostomy and we perform the closure of rectal stump. So this is Hartmann's procedure, and it is done for which patients? It is done for the patients who are having sigmoid malignancy. So sigmoid malignancy in elderly. This is done for sigmoid malignancy in elderly patient. In elderly patients. Imagine another situation. Patient is having malignancy where? In mid or lower rectum. So in mid or lower rectum, there is malignancy. In such cases, if patient comes with obstruction, what we are going to do? We are going to perform the defunctioning colostomy. After defunctioning colostomy, obviously the obstruction is relieved. When patient general condition improves, we send this patient for chemoradiation. And by chemoradiation, what will happen? The tumor is downstaged. And when this tumor is downstaged, then we go for what? Tumor resection and we perform colostomy closure. So here, first we perform defunctioning colostomy. So in emergency, what's the treatment? It is defunctioning colostomy. And after this defunctioning colostomy, we go for what? Chemoradiation. Why? Because we want to downstage the tumor. So we go for chemoradiation. Clear? And after downstaging with chemoradiation, we go for tumor resection. And apart from tumor resection, we perform colostomy closure. So tumor resection, and we do what? We do colostomy closure. Clear? So tumor resection and colostomy closure is done. Most common site of volvulus, that is sigmoid colon. So we are going to discuss sigmoid volvulus. It is the most common site of volvulus. Overall, this is the most common site of volvulus, and usually it is anti-clockwise. It can be clockwise also, but most commonly this is anti-clockwise. This is anti-clockwise. Okay, there are two predisposing factors for sigmoid volvulus. First, you can see this is the normal mesentery, but here you can see this is the narrow mesentery. And second, if the patient is having constipation, so what happens? If the sigmoid is having long narrow mesentery, can you see here? Long narrow mesentery, and it is loaded with what? Fecal matter, means constipation is there. So sigmoid is very prone for rotation. Counterclockwise. Clear? So what are the two predisposing factors you can see here? First, long narrow mesentery. Two problems: long narrow mesentery and constipation. And you know that this constipation, it's a big problem in elderly. So usually you are going to find the sigmoid volvulus in elderly patient who are having this long narrow mesentery and there is constipation. Since there is twisting, so here you can see, because of this twisting, what kind of obstruction is there? Obviously, patient is having large bowel obstruction. And what kind of obstruction? Obviously, this is closed loop obstruction. So the patient will be having signs and symptoms of large bowel obstruction like colicky pain, abdominal distension, and non-passage of feces and flatus. So in sigmoid volvulus, what are the clinical features? Clinical features here, patients are having signs and symptoms of large bowel obstruction, and diagnosis is also made by what? X-ray abdomen. So here also investigation of choice for diagnosis, that is X-ray abdomen, and you can see what are the findings. First, this is known as coffee bean sign. You can see here. So this is also coffee bean sign. Another sign which is important here, this is bent inner tube, and here you can see this is omega sign. So bent inner tube, omega sign, coffee bean sign, all of these are seen on X-ray. So this is frequently asked question, image based question on X-ray. What are the signs? Coffee bean sign, bent inner tube, or omega sign. Whenever we are going to perform barium enema, there are other signs like bird beak sign, ace of spade sign, and bird of prey sign. So here you can see this is bird beak sign. There are other signs which are seen on barium enema, ace of spade sign, bird of prey sign. We discussed bird beak sign on barium swallow. It is seen in achalasia cardia, and bird beak sign on barium enema. This is seen in sigmoid edit कर देना. We discussed that bird beak sign on barium swallow, it is seen in achalasia cardia, and bird beak sign on barium enema, this is seen in sigmoid volvulus. Since patient is having large bowel obstruction, obviously we have to treat. So how we are going to treat? We have to insert the colonoscope and we perform detorsion so that the general condition of patient is going to improve. By detorsion, obviously obstruction will be relieved. And after 3 days, we are going to perform elective sigmoid colectomy. This is the treatment of choice. The treatment of choice, that is colonoscopic detortion. This is colonoscopic detortion followed by elective sigmoid colectomy. Followed by elective sigmoid colectomy. And you know that elective surgeries are having lesser complications. So elective sigmoid colectomy, usually it is done after 72 hours. After 72 hours. So this is the treatment of choice for sigmoid volvulus. Cecal volvulus is a misnomer because here there is not only involvement of cecum, there is mainly involvement of cecum and ascending colon. So correct term should be cecocolic volvulus, and actually speaking, some part of ileum is also involved. So there is involvement of ileum plus cecum plus ascending colon. You can see here, ileum, cecum, some part of ascending colon. Usually this cecal volvulus is clockwise. How to remember? It starts with C. So it is clockwise. In this image, you can see the twisting starts from ileum. So whenever twisting starts from ileum, these patients will present with signs and symptoms of what? Ileal obstruction. Means important point, clinical features, patients will be having signs and symptoms of small bowel obstruction. So there is colicky pain, multiple episodes of bilious vomiting, and non-passage of feces and flatus. So here, patient presents with signs and symptoms of small bowel obstruction. Here also we make the diagnosis on X-ray abdomen. See the characteristic sign. So on X-ray you can see this is kidney bean sign. It is looking like kidney. So this is known as what? Kidney bean sign. So this is kidney bean sign, also known as comma shaped cecum. So on X-ray abdomen, there is kidney bean sign and comma shaped cecum. Here you cannot perform colonoscopic detorsion because there is involvement of cecum and some part of ileum. So what is the treatment here? The part which is involved in the volvulus, we have to resect that. So in this image you can see, since there is involvement of this part of ileum, so we are going to resect this ileum, cecum, ascending colon. So what? We perform ileocolectomy. And after performing ileocolectomy, what kind of anastomosis? We perform anastomosis between ileum and transverse colon. So this is known as what? Ileotransverse anastomosis. So the treatment is what? Treatment, it is ileocolectomy plus ileotransverse anastomosis. So it is ileocolectomy plus ileotransverse anastomosis. That's the treatment which is done for cecal volvulus. So this is all about intestinal obstruction. Now we are going to start small intestine, and first we are going to discuss the Meckel's diverticulum. In this image you can see this is the Meckel's diverticulum. What is the location? It is single, true, congenital, located on anti-mesenteric border. And you know that this is the most common congenital abnormality of midgut. What is the cause of Meckel's diverticulum? It is caused by persistent vitellointestinal duct, that is also known as omphalomesenteric duct. So it is caused by persistent vitellointestinal duct, that is also known as omphalomesenteric duct. You know that Meckel's diverticulum, it is characterized by rule of 2. So Meckel's diverticulum, it is seen in 2% of population. What is the length? It is 2 inches in length. Location, it is located 2 feet proximal to ileocecal junction. And symptomatic patients, most of the symptomatic patients are less than 2 years of age. So this is what rule of 2. It is characterized by rule of 2. Now see another problem. In Meckel's diverticulum, there is ectopic mucosa. So if you see this image, this patient is having ectopic mucosa. So here is the ectopic mucosa. What is the most common ectopic mucosa? It is gastric. So most common, it is gastric, followed by pancreatic, followed by colonic. So most common ectopic mucosa, gastric, followed by pancreatic, followed by colonic. And this ectopic gastric mucosa, obviously it is going to secrete what? Acid. So this acid is going to work in the surrounding, and because of that, what will happen? Patient will develop ulcer, and because of this ulcer, what will happen? Bleeding. So most common manifestation of Meckel's diverticulum, that is bleeding. What is the most common ectopic mucosa? It is gastric, followed by pancreatic, followed by colonic. How to remember? Mnemonic is GPC. Gastric, followed by pancreatic, followed by colonic. This is GPC. And we discussed that the most common symptom because of ectopic gastric mucosa, there is bleeding. So the most common presentation, that is bleeding. But what is the problem in adults? Most common symptom in adults. So imagine if if the patient is not symptomatic in childhood, it means in majority of such patients there is no ectopic mucosa. So here there is abdominal pain, and what is the cause of abdominal pain? Sometimes it is because of volvulus, sometimes intussusception, and sometimes because of diverticulitis. So most common symptom in adults, that is abdominal pain. This is abdominal pain. So how we can detect this ectopic gastric mucosa? The investigation of choice for diagnosis in Meckel's diverticulum, that is technetium pertechnetate scan. This is technetium pertechnetate scan. That is the investigation of choice. So investigation of choice for diagnosis, that is technetium pertechnetate scan. Now see the treatment. Now two situations are there. One, whenever there is Meckel's diverticulum with healthy base means there is no ulceration. And if there is Meckel's diverticulum with unhealthy base, means what happens? Near base, there is ulceration. So if there is healthy base, you are just going to excise the diverticulum. This is known as diverticulectomy. And if there is unhealthy base, we go for what? Resection and anastomosis. So Meckel's diverticulum with healthy base, we just excise the diverticulum. That is diverticulectomy. We perform diverticulectomy. And if there is unhealthy base, here we go for resection and anastomosis. RA. We perform what? Resection and anastomosis. In Meckel's diverticulum, there are certain conditions which are going to increase the risk of complications. What are those conditions? First, if patient is having narrow mouth diverticulum, if patient is having unhealthy base, and why there is unhealthy base? Because there is ulceration. Why there is ulceration? Because patient is having ectopic gastric mucosa. So narrow mouthed, unhealthy base, and if there is presence of ectopic gastric mucosa, all of these are going to increase the risk of complications in Meckel's diverticulum. Now we're going to discuss GI tuberculosis, gastrointestinal tuberculosis, and you know what is the most common organism responsible? It is Mycobacterium tuberculosis. So most common organism responsible, that is Mycobacterium tuberculosis, and you know that Mycobacterium bovis has been eliminated by public health measures. So it is Mycobacterium tuberculosis. Now see the pathway of spread. What is the first organ affected? The first organ affected is lungs. So how GIT is involved? Because there is production of sputum. So whenever we are going to swallow the infected sputum, this infected sputum reaches the GIT. So the first organ affected, this is lungs. And how GIT is involved? It is involved by swallowing of infected sputum. So it is involved by swallowing of infected sputum. This infected sputum reaches the terminal ileum where it is going to cause the oxidative stress and loss of epithelium. Because of that, there will be ulcer. But what happens? The earliest disease activity it is seen in submucosa because there is recruitment of lymphocytes. So earliest disease activity in GI tuberculosis, it is seen in which layer? It is seen in submucosa. Submucosa. And what is the most common site of GI tuberculosis? It is ileocecal region. Most common site, that is ileocecal region. So because of this oxidative stress and loss of epithelium, there is formation of ulcer. So what kind of ulcers are seen in tuberculosis? In tuberculosis, there is transverse ulcer. And what kind of ulcer is seen in typhoid? There are longitudinal ulcers. In this image, you can see in the tuberculosis, this kind of ulcer, you can see here. This is transverse ulcer. So transverse ulcers are seen in tuberculosis, and in typhoid you can see this kind of longitudinal ulcer. So in typhoid there is longitudinal ulcer, in tuberculosis there is transverse ulcer. So there are pathological types of tuberculosis. What's the most common type of tuberculosis? That is ulcerative variety. The most common type, ulcerative variety, it is responsible for 60% of cases. Hypoplastic, this is rare. It is seen in 10% cases. And sclerotic or fibrotic variety, here patient is going to develop established stricture. Here, this is responsible for 30% cases. Okay. Now, what are the manifestations of tuberculosis? Initially, patient is going to develop non-specific signs and symptoms like evening rise of temperature, low-grade fever, anorexia, weight loss, and night sweats. In all kinds of tuberculosis, initially these are non-specific signs and symptoms. But what happens in GI tuberculosis? Here you can see this is the ileum, this is the cecum, this is the appendix. So at the site of ulcer, what happens? At the site of ulcer, there is irritation. So initially patient is having diarrhea. But what happens? After some time, there is formation of established stricture. So if there is established stricture, this is usually passable stricture. So these patients will be having subacute intestinal obstruction. So this is partial obstruction. And because of this obstruction, what is the manifestation? Patients are having abdominal pain. So most common presentation, subacute intestinal obstruction, and the symptom will be abdominal pain. Simultaneously, patient will be passing feces and flatus because it's partial obstruction. So here, what is the most common symptom? Initially, patients are going to develop diarrhea, but after stricture, the most common symptom is abdominal pain. This is abdominal pain. In any kind of tuberculosis, what is the most common laboratory abnormality? There is raised DSR. Raised DSR, and this is seen in more than 90% patients. Second, if you perform ultrasound, there is a typical appearance that is known as club sandwich appearance. On ultrasound, there is club sandwich appearance. Club sandwich appearance. Why there is club sandwich appearance? Because of matted bowel loops, and what happens? There is collection of fluid in between the bowel loops. Investigation of choice for diagnosis of GI tuberculosis, and that is CCT, because you can assess the luminal abnormality as well as we can assess the extraluminal abnormality, means mesenteric lymph nodes, ascites, any kind of extraluminal problem. So that's why investigation of choice for diagnosis, it is GI tuberculosis. Second important point, in GI tuberculosis, obviously there is ascites and that is exudate. So whenever there is ascites, you can go for paracentesis. So what are the typical findings on paracentesis? So you have to remember the lymphocytes. You know that in tuberculosis there is lymphocytosis. So here, how many lymphocytes on paracentesis? You have to remember the count, more than 500 per mm cube. This is exudate, so protein content should be high. So how much is the protein content? More than 2.5 grams per deciliter. Why higher protein? Because this is exudate. Exudate SAG, it is less than 1.1. SAG is serum ascitic albumin gradient, and ADA, that is adenosine deaminase, it is raised. Adenosine deaminase, it is raised. So on the basis of paracentesis also, we make the diagnosis, but investigation of choice for diagnosis, that is CCT. Lots of questions are asked about the findings of barium meal follow through. Have a look. Now see what's going to happen. This is the ileum, this is the cecum. Ileum and cecum, this is IC angle. Usually it is 90 degree, this is appendix. So what happens in tuberculosis? There is pulled up cecum. So if there is pulled up cecum, cecum goes up, and when cecum goes up, you can see this is the angle. So IC angle, it becomes obtuse. So this is what obtuse IC angle. So in such patients, pulled up cecum is there. This is obtuse IC angle. And this obtuse IC angle, it is looking like goose neck. So what is the name of this deformity? This is goose neck deformity. obtuse IC angle, it leads to gooseneck. This leads to gooseneck deformity. Clear? Another important point, what happens? In ileum specifically, we discussed that there is formation of ulcer. So whenever there is formation of ulcer, what happens? Ileum becomes hyperirritable. So there is rapid emptying of barium into the colon, means cecum. Because of this rapid emptying, the ileum appears narrowed. So this is narrowed appearance of terminal ileum. And what's the name of this sign? It's very, very important. Name of this sign, this is Sterling sign. Name of the sign, that is Sterling sign. So what is Sterling sign? Because of hyperirritability of ileum, there is rapid emptying of barium. That's why there is narrowed appearance. Sometimes what happens, there is established stricture. So if there is established stricture, you can see that there is persistent narrowing of ileum. And this persistent narrowing of ileum, this is known as string sign of Cantor. So persistent narrowing of ileum because of established stricture, and this is known as string sign of Cantor. String sign of Cantor. So one special finding or special feature, you can see that any patient who is having ulcer in terminal ileum, that patient can have Sterling sign, and any patient who can have stricture in terminal ileum, that patient can have string sign of Cantor. That's why these are two non-specific signs. So Sterling sign as well as string sign of Cantor, these are non-specific, and these are also seen in Crohn's disease. So Sterling sign as well as string sign of Cantor, it is seen in both Crohn's disease and it is seen in GI tuberculosis. It's a frequently asked question. How it looks like? So first have a look of this picture. In this picture you can see that here is the IC junction. You can see here. This is the IC junction. So you can see that there is pulled up cecum. Pulled up cecum is there. In the second image you can see what? That this is the cecum, and here you can see this, because of persistent narrowing there is stricture. So what is the name of this sign? This is known as string sign of Cantor. This is known as string sign of Cantor. Clear? Another feature of GI tuberculosis. In this image you can see there is widely gaping thickened patulous IC valve with narrowed ulcerated terminal ileum. So widely gaping thickened patulous IC valve with narrowed ulcerated terminal ileum. And what is the name of this sign? This is known as inverted umbrella sign, also known as Fleischner sign. This was asked in a latest exam. So widely gaping thickened patulous IC valve, widely gaping thickened patulous IC valve with narrowed ulcerated terminal ileum. What's the name? It is also known as inverted umbrella sign, inverted umbrella sign, and another name is Fleischner sign. So this is also known as Fleischner sign. This was asked in the latest exam. Clear? So these are the named signs which are asked in exam. What? There is pulled up cecum, there is gooseneck appearance because of obtuse IC angle, Sterling sign, string sign of Cantor, inverted umbrella sign, also known as Fleischner sign. In tuberculosis, what is the treatment? Obviously, it's ATT with management of complications. There are certain situations in which we have to go for surgery. So what are the indications of surgery in GI tuberculosis? In cases of acute obstruction, our patient is having perforation, any patient in whom there is bleeding, there is abscess, or there is fistula formation. So in all these cases, we have to go for surgery in GI tuberculosis. Now the superior mesenteric artery syndrome, you can see here, there is compression of third part of duodenum by superior mesenteric artery. See the image? So in this image, you can see, this is the superior mesenteric artery, this part. This is superior mesenteric artery, and here you can see this is the third part of duodenum. So this superior mesenteric artery, it is going to compress this third part of duodenum. So this is known as what? Superior mesenteric artery syndrome. The obstruction is partial. That's why patient will be having colicky pain, but patient is going to pass feces and flatus. See the lateral view. In this image, you can see this is aorta, and this is the superior mesenteric artery. So there is angle between aorta and superior mesenteric artery. This is known as aortomesenteric angle. And how much is the normal aortomesenteric angle? Normally, it is 50 to 60 degree. But what happens? Why this angle is maintained? Because you can see there is fat pad. So fatty cushions are there. That's why this angle is maintained. Any patient in whom there is rapid weight loss, rapid gain of height, prolonged immobilization or cast application, in that case what happens? The angle becomes, you can see here, the angle becomes less than 20. And whenever this aortomesenteric angle becomes less than 20, normally how much? Normally it is 50 to 60 degree. So when angle is less than 20, here you can see this duodenum is being compressed by this superior mesenteric artery. So this is superior mesenteric artery syndrome. What are the other names of superior mesenteric artery syndrome? It is also known as Wilkie syndrome, also known as cast syndrome, because it can manifest after application of body cast. Anything in which there is loss of fat pad like rapid weight loss, rapid gain of height, prolonged immobilization, or body cast application, all these things can lead to superior mesenteric artery syndrome. And we discussed because of partial obstruction, what is the pain? What is the symptom? Patient is having abdominal pain. Since there is partial obstruction, that's why patient passes feces and fetus, but abdominal pain is there. Now, how you can make the diagnosis? We can make the diagnosis by hypotonic duodenography also and CT also. So diagnosis can be made by hypotonic. It can be made by hypotonic duodenography, or we can make the diagnosis by CT, or diagnosis can be made by CT. Now, how to manage? Majority of patients will be managed conservatively. So whatever the predisposing factor is there, you have to treat it. So if there is rapid weight loss, we encourage the patient for weight gain. Patient is immobilized in one particular posture, like supine position. So we ask the patient to lie prone after meals. If there is cast application in the body, we ask the patient to remove the cast. Even after conservative management, if there is no improvement, so there are two kinds of treatment. Have a look. In this image, you can see this is ligament of Treats. So what I can do, I can cut this ligament of Treats. So you divide the ligament of Treats because it is going to attach at DJ, and after that you mobilize the fourth part of duodenum. So division of ligament of Treats with mobilization of fourth part of duodenum, this is known as Strong's procedure. What's the name? This is known as Strong's procedure. This is one. Second, what you can do, you can perform the anastomosis between jejunum and duodenum. So if you perform the anastomosis, obviously this obstruction is bypassed. So this is what? DJ, duodenojejunostomy. So treatment of choice for superior mesenteric artery syndrome, that is duodenojejunostomy, and another surgical treatment which can be done in which there is no anastomosis, that is Strong's procedure. In majority of patients, we follow conservative management. In majority of patients, second option, we have Strong's procedure. So we discussed that what we are going to perform in Strong's procedure: division of ligament of Treats and mobilization of fourth part of duodenum. And but the treatment of choice, for superior mesenteric artery syndrome, that is duodenojejunostomy. We discussed two other topics. What? There is duodenal atresia and there is annular pancreas. So in annular pancreas and duodenal atresia, the treatment of choice is duodenostomy. So another important point, for annular pancreas and for duodenal atresia, in these cases the treatment of choice is DD, that is what? DD, duodenostomy. So you have to remember DJ, treatment of choice in superior mesenteric artery syndrome; DD, treatment of choice in annular pancreas and duodenal atresia. Now we are going to discuss small bowel tumor. So what is the most common small bowel tumor? That is stromal tumor followed by adenoma. So this is stromal tumor. Most of the small bowel tumors are benign. So this is stromal tumor followed by adenoma. And we already discussed when we were discussing intussusception that what is the most common small bowel tumor in children? Lymphoma. And lymphoma is the most common tumor responsible for intussusception in children. So most common small bowel tumor in children, it is lymphoma. This is lymphoma. After that, what is the most common malignant small bowel tumor? So you know, small bowel, it is lined by columnar epithelium. So malignancy is adenocarcinoma. So most common malignant small bowel tumor, that is adenocarcinoma. This is adenocarcinoma followed by carcinoid tumor. So it is adenocarcinoma followed by carcinoid tumor. Carcinoid tumor is very, very important. We are going to discuss in detail. Carcinoid tumors are neuroendocrine tumors. We discussed pancreatic neuroendocrine tumor. So you know that neuroendocrine tumor arises from neuroendocrine cell. So in small intestine, the carcinoid tumors are arising from enterochromaffin-like cells, ECL cells. Enterochromaffin-like cells, ECL cells. And these cells are located in the crypt of Leberkuchen. These cells are going to secrete or produce which substance? 5-hydroxytryptamine, and it is also known as serotonin. It is also known as serotonin. So, three important points that neuroendocrine tumors are going to secrete active substance or active hormone. Clear? It means they are symptomatic from the very beginning. Diagnosis is made in the laboratory after measuring the active substance or its byproduct. So what is the byproduct of 5-hydroxytryptamine? 5-hydroxyindole acetic acid that is detected in urine. And all neuroendocrine tumors are going to express somatostatin receptors except insulinoma. That's why investigation of choice for localization of most of neuroendocrine tumors, that is SRS. What is the full form? Somatostatin receptor scintigraphy. Now, important point, what is the most common site? And the most common site in most of the surgery books is written appendix. That's wrong. In DeVita and Harrison, it is given as bronchus. That's the correct answer. The most common site is bronchus, followed by ileum, followed by rectum, followed by appendix, followed by colon, followed by stomach. So, how to remember? Mnemonic is BIRAX. Mnemonic is BIRAX. Clear? It's bronchus, followed by ileum, followed by rectum, followed by appendix, followed by colon, followed by stomach. But if you're going to compare bronchus with small intestine means there is combined incidence in duodenum plus jejunum plus ileum. So if you see the combined incidence of duodenum, jejunum, ileum, it is more than bronchus. So overall, most common site is small intestine. Small intestine because it includes the combined incidence of duodenum, jejunum, ileum. So overall, it is small intestine followed by bronchus. But if small intestine is not given in the option, then we mark the bronchus. It's very easy to understand the pathophysiology. You know that there is 5-hydroxytryptamine, which is also known as serotonin, and it is metabolized by monoamine oxidase. Clear? Monoamine oxidase. And this monoamine oxidase, it is expressed in 3 organs. How to remember? LLB. 3 organs, LLB, mainly in the liver and lungs. Mainly in the liver, lungs, as well as brain, but mainly in the liver and lungs. So this monoamine oxidase, it converts 5-hydroxytryptamine to 5-hydroxyindole acetic acid, and it is excreted in urine. So this byproduct 5-hydroxyindole acetic acid, it is estimated in the urine. So urinary estimation of 5-hydroxyindole acetic acid, this is the investigation of choice for diagnosis. Investigation of choice for diagnosis, urinary estimation of 5-hydroxyindole acetic acid. Now, second situation, imagine any patient in whom there is excessive production of 5-hydroxytryptamine or serotonin. Means the production capacity exceeds the metabolic capacity. So whenever production capacity exceeds the metabolic capacity of 5-hydroxytryptamine, there is surplus serotonin in the body, and these patients are having manifestations, and these are known as manifestations of carcinoid syndrome. So what is the most common manifestation of carcinoid syndrome? There is flushing. Whenever production capacity exceeds the metabolic capacity of serotonin, patient is having carcinoid syndrome, most common manifestation, that is flushing. Apart from flushing, these patients are having wheezing, there is bronchospasm, there is diarrhea. One. Second, if patient is having GI carcinoid, what will happen? The 5-hydroxytryptamine, this is metabolized in the liver. But if patient is having carcinoid tumors outside GIT, so what will happen? 5-hydroxytryptamine, it is going into the systemic circulation via superior vena cava, inferior vena cava. It is entering into right atrium, then right ventricle, and then it goes to lungs, and it is metabolized or catabolized in lungs. Got it? So if I'm going to ask any patient in whom there is excessive serotonin, which side of heart will be affected, right side or left side? So obviously right side. Why? Because the catabolism of this serotonin occurs in the pulmonary capillaries. That's why right side of heart is exposed. Second question, the valve which comes in contact with serotonin first, that is most severely affected. That's why first there is tricuspid valve, this is most severely affected, then there is involvement of pulmonary. So what kind of abnormality is there? Yes, if there is abnormality in tricuspid, so these patients are having tricuspid regurgitation followed by pulmonary regurgitation, followed by tricuspid stenosis, followed by pulmonary stenosis. So this is carcinoid heart disease. The carcinoid heart disease mainly affects the right side of heart, right side of heart. And what is the most common valvular abnormality? This is very, very important. It is asked frequently. So what? Tricuspid more than pulmonary. So there is involvement of tricuspid more than pulmonary valve. So what is the abnormality which is seen? These patients are having TR followed by PR, followed by TS, followed by PS. So tricuspid regurgitation, followed by pulmonary regurgitation, followed by tricuspid stenosis, followed by pulmonary stenosis. In carcinoid tumors, the risk of malignancy depends on the location of tumor, size of tumor, depth of invasion, and growth pattern. Clear? So how to remember? The mnemonic is LST growth. Risk of malignancy in carcinoid tumors depends on LST growth. L means location of tumor, S size, D depth of invasion, and growth pattern. Now we are going to discuss the small bowel carcinoid. You know, this is the small bowel and this is the mesentery of small bowel. Mesentery. So what happens? The tumor, small bowel carcinoid, the tumor is small. But what is the problem? Around this tumor, there is extensive fibrosis. So because of this extensive fibrosis, what is the problem? These patients are having obstruction. So because of this fibrosis, there is obstruction, and that's why the patients are having abdominal pain. So what's the problem in small bowel carcinoid? In small bowel carcinoid, though the tumor is small, but the most common symptom, it is because of obstruction, and the most common symptom, that is abdominal pain. Most common symptom, that is abdominal pain. We already discussed how to make the diagnosis. Investigation of choice for diagnosis, urinary estimation of 5-hydroxyindole acetic acid. So here the investigation of choice for diagnosis, that is estimation of 5-hydroxyindole acetic acid in urine. Estimation of 5-hydroxyindole acetic acid in the urine. Second, initial investigation for localization and staging, that is SRS, somatostatin receptor scintigraphy. And if you see the best investigation for localization, this is DOPA PET. This is DOPA PET, and this is frequently asked question. You have to remember, it is DOPA PET. This is frequently asked question. So initial investigation for localization and staging, SRS, but best investigation for localization, that is DOPA PET. What's the treatment for carcinoid tumors? We go for segmental resection with en bloc lymphadenectomy. So the treatment is, it is segmental resection. This is segmental resection with en bloc lymphadenectomy. So segmental resection with en bloc lymphadenectomy. This is the treatment. Segmental resection with en bloc lymphadenectomy. Clear? Treatment of carcinoid tumor. It's very important. It is asked in medicine, surgery, pathology. What is the normal length of small bowel? Normal length is 600 centimeter. So 6 meter, that is 600 centimeter. When we are going to label that patient is having short bowel syndrome, whenever the small bowel length is less than 200 centimeter. So if the length is less than 200 centimeter, patient is having short bowel syndrome. So what happens? Short bowel syndrome, it is caused by massive resection of small bowel. So conditions in which we perform massive resection like mesenteric ischemia, mesenteric trauma, midgut volvulus, Crohn's disease, in all these cases, there is increased risk of short bowel syndrome. The massive resection of small bowel in mesenteric ischemia, mesenteric trauma, midgut volvulus, Crohn's disease leads to short bowel syndrome. So what are the manifestations of short bowel syndrome? You can have a look. See this image. This is ileum. This is cecum, this is appendix. What are the two unique functions of terminal ileum? You know that there is B12 absorption and there is enterohepatic circulation of bile salt. B12 absorption and enterohepatic circulation of bile salt. So any patient in whom terminal ileum is resected, what will happen? There is impaired, what happens? Impaired B12 absorption and patient will develop megaloblastic anemia. So what's the cause? Because of impaired absorption. It's because of impaired absorption of B12 when terminal ileum is resected. Second, because of impaired enterohepatic circulation of bile salt, what will happen? Most of the bile salt will be going into the colon. So the patient is going to develop cholesterol gallstone because of impaired enterohepatic circulation of bile salt. Bile salt. Now what will happen? If this bile salt is not absorbed in the terminal ileum, it enters. Where it enters? It enters into the colon. And in colon, it is going to irritate the colon. So because of irritation of colon, patient is having watery diarrhea. So what is the cause of choleratic diarrhea? It is because of unabsorbed bile salts. Unabsorbed bile salts causes watery diarrhea because of irritation in the colon. It's because of unabsorbed bile salts. Whenever we are going to resect the jejunum, most of the absorption is occurring in the jejunum. So if there is loss of absorptive surface, what will happen? Malabsorption. So if there is malabsorption, what will happen? Obviously, free fatty acids will be there in the lumen because it is not absorbed. Free fatty acid is there in the lumen. So what will happen? It is going to bind with calcium. Free fatty acid binds with calcium. This calcium was for oxalate. But now it is binding with free fatty acid. So what happens? This calcium is not available. And when this calcium is not available for oxalate, the free oxalates are absorbed in the colon. And when it is absorbed in colon, free oxalates are absorbed in colon. Because of increased level of oxalate, what will happen? Patient will be having oxalate renal stones. So these are the manifestations of short bowel syndrome. There is another manifestation, especially the patients in whom there are other manifestations. Imagine in some patients this IC valve is removed. When the IC valve is removed, what will happen? There will be free reflux of fecal matter into the ileum. And because of this, what's going to happen? If IC valve is removed, there are two symptoms. Patient is having bacterial overgrowth, and patients are having diarrhea. This symptom is only seen when IC valve is removed. When IC valve is removed. And you know that catabolism of gastrin occurs in small bowel mucosa. So in patients of short bowel syndrome, there is increased gastrin, means patients are having hypergastrinemia. These patients are having hypergastrinemia. So whenever we perform the massive resection of small bowel in post-operative period, how we manage the patient? We give TPN. So what's the management? In post-operative period, we give total parenteral nutrition, right? But what? Lifelong, you cannot give total parenteral nutrition because it is having its own complications. That's why, what is the treatment of choice? Treatment of choice in short bowel syndrome. And you know, the treatment is small bowel transplantation. So the treatment is small bowel transplantation. So the treatment of choice for short bowel syndrome, that is small bowel transplantation. Clear? So this is how we manage short bowel syndrome, and this is all about small intestine. Now we are going to start large intestine. First of all, we are going to discuss the Hirschsprung's disease. In Hirschsprung's disease, there is absence of ganglion cells, and the absence of ganglion cells, this is seen in both Auerbach plexus as well as Meissner's plexus. How much is the incidence? Incidence is 1 in 5,000 live births. Incidence? This is 1 in 5,000 live births. What is the most common site? And the most common site, it is rectum followed by sigmoid. Rectum followed by sigmoid. And you know that it is a type of neurocristopathy. See what's the problem here? In this image, you can see this is the normal colon, this is the normal rectum. In the second image, you can see this part is affected. So this part of the rectum is affected, and you can see here the part of bowel which is affected, that is contracted. So affected part is contracted and the normal part is dilated or distended. Since affected part is contracted, it means what? The patient will be having signs and symptoms of large bowel obstruction. So since here rectum, it is narrowed, so patient will be having signs and symptoms of large bowel obstruction. And you know that what are the signs and symptoms of large bowel obstruction? Patient will be having abdominal pain, especially in the lower abdomen. Patient will be having abdominal distension and non-passage of feces and flatus. What happens? In some of the patient, this is partial obstruction. So after birth, what you're going to notice that the child is having, or this newborn baby is having abdominal distension. That is the most common presentation. The patients who are having large bowel obstruction, there is no passage of feces and flatus. So patients of Hirschsprung's disease also, what happens here? There is no passage of meconium within 24 hours. The treatment protocol is also like large bowel obstruction. What? We perform colostomy first. After performing colostomy, when the general condition of patient improves, then we treat the disease itself. Clear? So here also, initially we perform colostomy and later we go for definitive operation. So what is the most common symptom or most common presentation here? Patient is having abdominal distension. So these patients just after birth, they have abdominal distension and there is delayed passage of meconium, means there is no passage within 24 hours. So no passage of meconium within 24 hours means patient is going to pass meconium after 24 hours. How we make the diagnosis? Since there is absence of ganglion cells, so investigation of choice for diagnosis, it is biopsy. So obviously we perform what? Rectal biopsy. Investigation of choice for diagnosis, it is rectal biopsy, and here suction biopsy is preferred over full thickness biopsy. Now, what's the management? If the patient is having short segment disease, we perform extended myectomy. For short segment disease, we perform extended myectomy. Extended myectomy. And whenever patient is having long segment disease, here we perform temporary colostomy followed by definitive operation. So we perform temporary colostomy followed by definitive operation. It is followed by definitive operation. Definitive operation. And this question is also asked frequently, that what are the names of surgeries which are done. So the names of surgeries which are done: Swenson, Duhamel, Sowe. So names of operation, it is Swenson, this is Swenson, Duhamel. So this is Swenson, Duhamel, Sowe. These are the names of operation which are done in Hirschsprung's disease. What is the most common site of colonic diverticulosis? It is sigmoid colon. Most common site, that is sigmoid colon. Clear? And you know that colonic diverticulosis, this is the most common cause of significant lower GI bleed. So how much bleeding? Sometimes 100 ml, 200 ml, even 300 ml bleeding occurs from colonic diverticulosis. Most common site is sigmoid colon, but bleeding is more common from the right side of colon. Most patients who are having colonic diverticulosis, most patients are asymptomatic. Only 10 to 30% patients are symptomatic. And why patients are symptomatic? Because of complications. So what percentage of patients are symptomatic? Only 10 to 30%. And these patients are symptomatic because of complication. One of the complication is what? Diverticulitis. So diverticulitis is a misnomer. What happens? There is no inflammation of diverticula itself. What happens? There is peridiverticulitis. So these patients are having perforation, and after perforation, what happens? There is peridiverticulitis. So diverticulitis is a misnomer. These patients are actually having peridiverticulitis. So what is the manifestation? Because of peridiverticulitis, there is perforation. So inflammation is there around diverticula. So what kind of symptom? These patients are having pain and tenderness. Pain and tenderness. And where is the pain and tenderness? This pain and tenderness is there in left iliac fossa. So pain and tenderness is there in left iliac fossa. There is a classification system which is frequently asked related to complicated diverticulitis, and the name of this classification is Hinch's classification. So this is frequently asked question. First, what is stage 1? Here you can see there is pericolic or mesenteric abscess. So here, small or confined pericolic or mesenteric abscess, that is stage 1. What happens in stage 2? Here you can see there is large abscess extending into pelvis. So what? This is walled off pelvic abscess. So in stage 2, there is walled off pelvic abscess. And here in stage 3, what kind of peritonitis? Here you can see there is purulent peritonitis. So in stage 3, there is purulent peritonitis. And what happens in stage 4? Here you can see in stage 4, there is fecal discharge. So there is fecal peritonitis. So this is the Hinche classification which is asked frequently. Stage 1, pericolic or mesenteric abscess. Stage 2, that is walled off pelvic abscess. Stage 3, it is purulent peritonitis. And stage 4, that is fecal peritonitis. What are the complications of colonic diverticulosis? First, hemorrhage. This hemorrhage is painless and profuse. It is painless and profuse. So we discussed that colonic diverticulosis is the most common cause of significant lower GI bleeding. It can lead to perforation, and because of this perforation, patient will be having pericolic abscess. If perforation occurs, so patient is going to have pericolic abscess. Sometimes there is intestinal obstruction, and sometimes there is fistula formation. So what is the most common type of fistula? If you see this image, there is fistula between the bladder and the colon. This is colovesical fistula. And what is the most common cause of colovesical fistula? The most common cause of colovesical fistula, that is what? Colonic diverticulosis. So what kind of fistula? The most common type of fistula which is seen, that is colovesical, and most common cause of this colovesical fistula, that is colonic diverticulosis. These are the complications. Whenever there is colovesical fistula, via this fistula, fecal matter goes into the bladder and it comes out in the urine. So patient is having pneumaturia, fecaluria, recurrent UTI. What is the investigation of choice for diagnosis of colonic diverticulosis? And that is what? Barium enema. So here you can see in this image, what is the finding on the barium enema? So in this image, you can see this kind of appearance, and this is known as what? Sawtooth appearance. So on barium enema, there is sawtooth appearance. Sawtooth appearance. Clear? In patients of colonic diverticulosis. Now see the shift or twist in the question. When patient is having diverticulitis, there is inflammation around diverticula. Here, investigation of choice for diagnosis, it is CCT. So investigation of choice for diagnosis of colonic diverticulitis, that is CCT. Management, we have two options, either conservative management or we can go for surgery. Most of the patients are going to improve after conservative management. If you are planning surgery, what kind of surgery should be done? You already told me that the most common site of colonic diverticulosis, that is sigmoid colon. So here elective surgery is preferred. So we perform elective sigmoid colectomy with primary anastomosis. So what kind of surgery? Here we perform sigmoid colectomy. So we perform sigmoid colectomy with primary anastomosis. So sigmoid colectomy plus primary anastomosis is done. This is the management of colonic diverticulosis. Now see what are the types of colorectal polyps. It can be neoplastic or non-neoplastic. Neoplastic polyps are also known as adenomatous polyp. Neoplastic polyps, these are also known as adenomatous polyp. Clear? So what are the types of neoplastic polyp? The most common type, that is tubular. And which one is most malignant? It is villus. So most common, it's tubular, and most malignant, that is villus. Most malignant, that is villus. Now see the non-neoplastic polyps. Overall most common, or I should say most common type of non-neoplastic polyp, that is hyperplastic. So hyperplastic is actually overall most common. The second type is hamartomatous, which is further divided into juvenile polyp and the Peutz-Jeghers polyp. And the third polyp is inflammatory polyp. And you know that this is inflammatory polyp. So it is seen in inflammatory bowel disease. It is also known as pseudopolyp. Pseudopolyp. And in inflammatory bowel disease, pseudopolyp, it is more common in ulcerative colitis or Crohn's disease. So this is more common in ulcerative colitis. So this is the classification of polyp. So if we see overall, which one is most common? Overall, hyperplastic. What is the most common type of neoplastic polyp? That is tubular. And most malignant colorectal polyp, that is villus. So we discussed that juvenile polyp, it is a type of hamartomatous polyp. Usually it is single, seen in children less than 5 years of age. And what is the most common site? It is seen in rectum. Single polyp in the rectum. So what is the presentation? Patient presents with bleeding PR. So patient presents with bleeding per rectum. And how we are going to treat it? The treatment is polypectomy. So in juvenile polyp, what is the treatment? We go for polypectomy. Second is Peutz-Jeghers polyp. So it is seen in Peutz-Jeghers syndrome. So in Peutz-Jeghers syndrome, there are multiple hamartomatous polyp. In short, it is known as PJS. So what is the most common site of the polyp? S means small intestine. And in small intestine, where exactly? J means jejunum. So most common site, small intestine. And in small intestine, which particular part? Jejunum. What is the most commonly mutated gene? It is LKB1. This is LKB1 or STK11, and it is located on chromosome number 19. So gene is LKB1 STK11 and it is located on chromosome number 19. From distance also you can make the diagnosis of Peutz-Jeghers syndrome. Why? Because patients are having hypermelanotic macules. So in the image you can see there are presence of hypermelanotic macules. It is present over lips, perioral lesion and buccal mucosa. And if you go for the histology, what kind of polyp is there? Hamartomatous polyp. And here you can see there is tree-like pattern. This is known as arborization. So there are two special features which are asked in exam. One is arborization and the second is pseudo-invasion. Arborization and there is pseudo-invasion. Pseudo-invasion. And we discussed carcinoma pancreas, in which we discussed that Peutz-Jeghers syndrome increases the risk of carcinoma pancreas, and there is maximum risk by Peutz-Jeghers syndrome. So hereditary factors are risk factor for carcinoma pancreas. Which hereditary factor is having maximum risk? Peutz-Jeghers syndrome. So you know that it is going to increase the risk of carcinoma pancreas. It increases the risk of carcinoma pancreas, and there is maximum risk by Peutz-Jeghers syndrome. Now see the adenomatous polyp. We discussed that adenomatous polyp, it's a neoplastic polyp. So what are the risk factors, or what are the conditions which are going to increase the risk of adenomatous polyp? How to remember? Mnemonic is USA. U means ureterosigmoidostomy, S means Streptococcus bovis bacteremia, and A means acromegaly. These are the factors which are going to increase the risk of adenomatous polyp. Then there are factors which are going to increase the risk of malignancy in adenomatous polyp. First, we discussed that villus polyp, it is having maximum risk of malignancy. And if you are going to compare sessile polyp and pedunculated, sessile polyps are having maximum risk. Third, size. So whenever the size of polyp it is more than 2 centimeter, it is having high risk. Another important point, there are two polyposis syndromes which are frequently asked. One is FAP and the second, there are two syndromes associated with adenomatous polyp. One is FAP and second is HNPCC. FAP, it is responsible for 1% of colorectal cancer in population. HNPCC, this is responsible for 5% of colorectal cancer in the population. Clear? How much is the risk of malignancy in FAP? There is 100% risk of malignancy. So in FAP, there is 100% risk of malignancy. And how much risk of malignancy is there in HNPCC? Up to 80. So risk of malignancy, it is up to 80%. Clear? That's why prophylactic treatment is done in FAP. Here, in FAP, we go for prophylactic treatment, but in HNPCC, we don't go for prophylactic treatment. Why? Because the risk of malignancy is up to 80, means all patients are not going to develop the malignancy. So one by one, we are going to discuss. First, we are going to discuss FAP. Both FAP as well as HNPCC are autosomal dominant. Clear? What is the mutated gene in FAP? It is APC gene, and the full form is adenomatous polyposis coli gene. It is located on chromosome number 5, Q21. Q means long arm of chromosome number 5. How many polyps are there? Adenomatous polyps. The number is more than 100. And how much is the risk of malignancy? There is 100% risk of malignancy. Polyp formation begins at what age? It starts at 15 years of age. Polyp formation begins at 15 years of age, and 100% patients are going to develop malignancy by 40 years of age. So 100% patients are going to develop malignancy by 40 years of age. In this image, you can see patients are having multiple polyps. So what happens? Most common presentation, this patient will be having bleeding PR. So patient is having more than 100 polyps. So most common presentation, bleeding PR. How we are going to make the diagnosis? If you are going to perform colonoscopy, you are going to visualize more than 100 polyps. And if you go for biopsy, what kind of polyp? It is adenomatous. So investigation of choice for diagnosis. In this case, investigation of choice for diagnosis, it is colonoscopy plus biopsy. This is what colonoscopy plus biopsy. Since the patient is having 100% risk of malignancy, so what you're going to do? You're going to remove the whole colon. So you can see here, I'm going to remove the whole colon. I'm going to remove the whole rectum. So the name of this surgery, it is total proctocolectomy. So what is the name of surgery done here? We are performing total proctocolectomy. So you remove the whole colon as well as rectum. Now you are left with what? Ileum, and you are left with anal canal. So we have to perform anastomosis between ileum and anal canal. How? I create a pouch, and after creating the pouch, I perform the anastomosis. So the pouch can be S-shaped, J-shaped, W-shaped. Most preferred is J-shaped pouch, and this is known as ileal pouch anal anastomosis. So what is the treatment of choice? The treatment of choice is total proctocolectomy plus ileal pouch anal anastomosis. Total proctocolectomy plus ileal pouch anal anastomosis. And you know, we are mainly performing pelvic surgery because we are performing proctocolectomy. Rectum is also being removed. So what is the post-operative complication? Most common complication is small bowel obstruction. Since pelvic surgery is being done here, so what is the most common complication? The most common complication, that is small bowel obstruction, and this small bowel obstruction, it is seen in 25% of patients. So small bowel obstruction, it is seen in 25% of patients. You know that FAP is autosomal dominant. So if patient is having kids, more than 50% of kids will be having this disease. So what is the investigation of choice for screening of family members of FAP? We go for APC gene testing. We go for APC gene testing. And if mutation is positive, total proctocolectomy is recommended in this patient. Next condition is HNPCC. And you know what is the full form of HNPCC? This is hereditary non-polyposis colorectal cancer. It is caused by mismatch repair gene abnormality. How many chromosomes are involved here? There are total 3 chromosomes which are involved, 2, 3 and 7. And how many genes are involved? Total number of genes involved, 7 genes. 7 genes are involved, and in 90% cases, only 2 genes are responsible. So for 90% cases, there is HMLH1 and second is HMSH2. HMLH1 and HMSH2, these are the 2 genes which are responsible for 90% cases of HNPCC. There are 2 criteria which are used. One is modified Amsterdam criteria. It is used to select at-risk patients of HNPCC. And there is revised Bethesda guidelines. It is used for detecting microsatellite instability. The modified Amsterdam criteria, it is used to select at-risk patient. Used to select at-risk patients for HNPCC. And revised Bethesda guidelines, this is used for detecting microsatellite instability. MSI, that is microsatellite instability in patients of HNPCC. We discussed that risk of malignancy, it is up to 80%. That's why prophylactic treatment is not done. You know that what is the other name of HNPCC? Other name is Lynch syndrome. It is further divided into Lynch 1 and Lynch 2. What is Lynch 1 and what is Lynch 2? In Lynch 1, there is only one type of malignancy. What? In Lynch 1, patient is having colorectal cancer only. And in Lynch 2, apart from colorectal cancer, these patients are having extra-intestinal malignancy. So with colorectal cancer, there is extra-intestinal malignancy. Clear? So what is that most common extra-intestinal malignancy in patients of HNPCC? Carcinoma endometrium, followed by carcinoma stomach, that is gastric, followed by ovarian cancer. So the most common extra-intestinal malignancy, it is endometrial. This is endometrial, followed by gastric, followed by ovarian. So endometrial, followed by gastric, followed by ovarian. Clear? So how to remember? Mnemonic is EGO. Endometrial, followed by gastric, followed by ovarian. So this is EGO. The prophylactic treatment is not done in patients of HNPCC, but we have to start the surveillance colonoscopy. And this surveillance colonoscopy, it should be started at 20 years of age. If patient develops carcinoma colon, so what you have to do? You have to perform total colectomy. And if you are going to perform total colectomy, what kind of anastomosis is done? Ileorectal. So if patient develops CO colon, we perform total colectomy. Total colectomy is done. And what kind of anastomosis? Plus ileorectal anastomosis. We perform ileorectal anastomosis. Clear? Since rectum is still there and having risk of malignancy, for that we perform annual proctoscopy. Another situation, imagine a female who is having 2 kids, means she has completed the family. So which organ should be removed? In such patients, we go for transabdominal hysterectomy plus bilateral salpingo-oophorectomy. So what we perform here? We perform transabdominal hysterectomy plus bilateral salpingo-oophorectomy. Question, why? Because we discussed that apart from colorectal cancer, there is increased risk of extraintestinal malignancy. And what was the mnemonic? It was EGO. E means endometrial, G means gastric, O means ovarian. So we can easily remove this endometrium and ovary. Means we remove the uterus, we remove bilateral ovary. So the treatment is transabdominal hysterectomy plus bilateral salpingo-oophorectomy. At what age screening should be done for colorectal cancer? The screening for colorectal cancer, it should be started at 50 years of age. Screening should be started at 50 years of age. We can go for fecal occult blood testing, and this is performed annually after 50 years of age. We can go for flexible sigmoidoscopy, and this should be performed every 5 yearly. So every 5 years we perform flexible sigmoidoscopy. Another option we have, that is double contrast barium enema, which should be done every 10 years, and we can also go for colonoscopy, and again this colonoscopy should be done every 10 years. Now out of these, which one is most preferred investigation? The most preferred is colonoscopy. For screening of colorectal cancer, most preferred investigation that is colonoscopy. If colonoscopy is contraindicated, imagine if it's contraindicated, in that case we go for double contrast barium enema. So most preferred colonoscopy. If it's contraindicated, then we go for double contrast barium enema. Now see what are the risk factors for colorectal cancer. Risk factors are smoking, alcohol, high fat diet which can lead to obesity, so that is the risk factor. And you know that FAP and HNPCC, these are having adenomatous polyp, so this is also a risk factor. Adenomatous polyp is a risk factor, and the risk factors for adenomatous polyp we discussed USA: ureterosigmoidostomy, Streptococcus bovis bacteremia, acromegaly. These are the risk factors. Inflammatory bowel disease, both ulcerative colitis as well as Crohn's disease are the risk factors, and the risk is equal in both. So both ulcerative colitis as well as Crohn's disease, these are going to increase the risk of colorectal cancer. So here there is similarity between colorectal cancer if we talk about the risk factors. Otherwise, carcinoma colon is a totally different malignancy. Carcinoma rectum is totally different malignancy. So we are going to discuss first carcinoma colon. Carcinoma rectum we will discuss in the chapter rectum and anal canal. What is the most common site of carcinoma colon? It is sigmoid. Most common site of carcinoma colon, sigmoid. Nowadays, least common is also asked. So what is the least common site of carcinoma colon? That is hepatic flexure of colon. Least common site, it is hepatic flexure of colon. And what is the most common site of metastasis in GI malignancies having hematogenous spread? So obviously it is liver. It is liver. What is the chemotherapy regimen which we give in carcinoma colon as well as carcinoma rectum? It is FOLFOX4. So the chemotherapy, it is FOLFOX4. FOLFOX4. Fol means, you can see here, folinic acid, and the other name is leucovorin. F means 5-fluorouracil, and ox means oxaliplatin. So it is FOLFOX4. Coming to the clinical features, symptoms depend on the location of the tumor. You know that in right-sided malignancies, bleeding is more common, and in left-sided malignancies, obstruction is more common. That's why overall most common symptom, it is abdominal pain. Why? Because the most common site is sigmoid colon. So most common symptom, it is abdominal pain because of obstruction. Because of obstruction. Why? Because obstruction is more common on left side. In this image, you can see in the right colon, what kind of growth is there? There is ulceroproliferative or fungating growth. Here, bleeding is more common. And in the left colon, you can see this kind of growth is there. And what is this kind of growth? This is annular or stenosing growth. So whenever there is annular or stenosing growth, obstruction is more common. So in right colonic malignancy, here, what kind of growth? It is ulceroproliferative or fungating. It is ulceroproliferative or fungating. Clear? And we discussed what is more common. Bleeding is more common. Bleeding is more common. More common. What kind of growth is there in left colonic malignancy? Here, there is annular or stenosing growth. Annular or stenosing growth. So in left colonic malignancy, what is more common? Here, obstruction is more common. In left colonic malignancy, obstruction is more common. And you know that obstruction manifests as what is the most common symptom? Abdominal pain. So we already discussed overall most common symptom is abdominal pain. Why? Because malignancy is more common on the left side. Now, what is the investigation of choice for diagnosis of carcinoma colon? Obviously, it is colonoscopy with biopsy. Investigation of choice for diagnosis, it is colonoscopy with biopsy. And what is the investigation of choice for staging of carcinoma colon? This is CCT. Investigation of choice for staging, CCT. Coming to the management, if it is TIS means carcinoma in situ or patient is having polyp, we go for polypectomy. Whenever patient is having stage 1 or stage 2 malignancy, what is sufficient? Here, segmental resection. So for stage 1 and for stage 2, we go for segmental resection. Whenever patient is having stage 3, here we have to give adjuvant chemotherapy. So apart from segmental resection, we have to give adjuvant chemotherapy. For metastasis, that is stage 4, we have two options. If up to 3 metastases are there in a single organ, either liver, lungs, or brain, we can perform the excision of metastasis, that is known as metastasectomy. So for stage 4, we have two options, metastasectomy. If up to 3 metastases to a single organ, plus palliation by chemotherapy. And if 4 or more metastases are there or multiple organs are involved, in that case only palliation is done. So this is how we manage the patients of carcinoma colon. Which organism is responsible for pseudomembranous colitis? It is caused by Clostridium difficile. Clear? And what is the characteristic appearance on CCT? So if you see this image, there is presence of pseudomembrane. This is the lumen. Clear? So this is pseudomembranous colitis, and how it looks like? It looks like this accordion. So on CCT, what kind of sign? You can see here, this is accordion sign. So on CCT, there is accordion sign. In pseudomembranous colitis, on CCT, there is accordion sign. Ischemic colitis. Tell me what is the most common site? The most common site of ischemic colitis, that is splenic flexure of colon. Most common site, it is splenic flexure. So this is splenic flexure of colon. Whenever we perform X-ray or we perform barium enema, in both of these, what you're going to find, you can see here, this is known as thumb printing. So on barium enema also, and on X-ray also. So on X-ray as well as on barium enema, what we find, there is thumb printing. So in ischemic colitis, the characteristic appearance, thumb printing, seen both on X-ray as well as on barium enema. What is the definition of lower GI bleeding? So here, bleeding occurs distal to ligament of Treats. What is the most common site of lower GI bleeding? Most common site, it occurs from colon. And bleeding occurs from which side of colon mainly? Mainly it occurs from the right side of colon. If you see the most common cause of lower GI bleeding, there is little amount of bleeding occurring from hemorrhoids. So overall, most common cause of lower GI bleeding, it is hemorrhoids. But how much bleeding is there? 1 ml, 2 ml, 5 ml, something like that. So what is the most common cause of significant lower GI bleeding, where 100 ml, 200 ml or 300 ml of blood is coming? That is colonic diverticulosis. This is colonic diverticulosis. Clear? What is the most common cause of significant, small bowel bleeding? So significant small bowel bleeding, it is caused by angiodysplasia. Clear? And the most common cause of occult lower GI bleeding means hidden. Occult means hidden. So this is what? Vascular ectasia. So these are the important points related to lower GI bleeding, and this is all about large intestine. Now we're going to discuss inflammatory bowel disease, and majority of questions in inflammatory bowel disease are asked in relation to differences between Crohn's disease and ulcerative colitis. So in detail, we are going to discuss the differences. First, see the macroscopic features of Crohn's disease and ulcerative colitis. You know that in Crohn's disease, any part of GIT can be involved. From mouth to anus, any part can be involved, but there are skip lesions. So what? It is segmental. It's a segmental disease with skip lesions, or there are skip areas. But what happens in ulcerative colitis? First there is involvement of rectum, and then the lesion move cranially upwards. So there is involvement of rectum, then sigmoid, then descending colon, and then transverse colon. So here there are continuous areas, continuous lesions without any skip areas. Now location. What is the most common part of GIT involved in Crohn's disease? There is involvement of ileum plus cecum. Sometimes there is involvement of ascending colon. So most commonly ileum and cecum involvement. After that, there can be involvement of ascending colon. And in ulcerative colitis, disease starts from rectum, then it is going to involve sigmoid and it move cranially upwards. Extent, you know that in Crohn's disease, all the three layers of bowel are involved. Means full thickness of bowel is involved. So this is transmural. It is transmural. But what happens in ulcerative colitis? Microscopically, there is involvement of only mucosa and submucosa, microscopically. But macroscopically, it is superficial and what it is confined to mucosal layer. But microscopically, there is involvement of mucosa plus submucosa. If you see the ulcer, what kind of ulcers are seen in Crohn's disease? There are serpiginous ulcer and it can progress to deep ulcers. Whereas in ulcerative colitis, there are superficial mucosal ulcers. You know, pseudopolyps, these are more common in which one? Crohn's disease or ulcerative colitis. So you know that pseudopolyps are more common in ulcerative colitis. Fibrosis and stricture. Fibrosis and stricture, this is more common in Crohn's disease. So fibrosis and stricture, it is more common in Crohn's disease. Since there is extensive fibrosis in Crohn's, what happens? There is shortening. So because of fibrosis, there is shortening. In cases of ulcerative colitis also, shortening occurs, but here shortening is not due to fibrosis, it is because of contraction of muscularis. So in ulcerative colitis, the shortening occurs because of contraction of muscularis. So these are the macroscopic features. Now see microscopic features. Now see the microscopic features of Crohn's disease and ulcerative colitis. So we already discussed that depth of inflammation in Crohn's disease, it is transmural, means there is involvement of what? Mucosa plus submucosa plus muscularis propria, and in ulcerative colitis there is involvement of only mucosa and submucosa. Second, type of inflammation. So in Crohn's disease there is non-caseating granuloma, presence of non-caseating granuloma, and there are mononuclear cells infiltrate. Whereas in ulcerative colitis there is non-specific acute and chronic inflammatory cells, presence of non-specific. So there is non-specific acute and chronic inflammatory cells in ulcerative colitis. Mucosal changes. So what happens in Crohn's disease? There are patchy ulcerations. And if you see the mucosal changes in ulcerative colitis, there is hemorrhagic mucosa with ulceration. In Crohn's disease, the submucosa is widened. What is the cause of widening of submucosa? Widening of submucosa, it is because of edema and presence of lymphoid aggregates. But in ulcerative colitis, the submucosa is either normal or it is reduced. Either normal or it is reduced in the width. If you see muscularis in Crohn's disease, it is infiltrated by inflammatory cells. But we discussed that in ulcerative colitis, muscularis propria, that is spared. And we discussed two important findings. Fibrosis, stricture, these are more common in Crohn's disease. So fibrosis is present, but in ulcerative colitis, fibrosis is absent. Now see the complications in Crohn's disease and in ulcerative colitis. So another important point, fistula. Fistula, whether it is internal or external, this is more common in Crohn's disease. Perineal involvement, that is more common in Crohn's disease. But fistula, it's rare in ulcerative colitis. So you can see here, both external as well as internal fistula, it is common in Crohn's disease. So it is seen in what percentage of patients? Seen in 10% of patients. But fistula, it is rare in ulcerative colitis. Now, malignant change. If you see the colon cancer, risk of malignancy, risk of colon cancer, it is equally common in ulcerative colitis as well as Crohn's disease. But small intestinal malignancy, this is more common in Crohn's disease. So small intestinal malignancy, this is more common in Crohn's disease. And you know that for cholangiocarcinoma, ulcerative colitis is a risk factor. So here, risk of cholangiocarcinoma is more in ulcerative colitis as compared to Crohn's. So here, it is more in ulcerative colitis as compared to Crohn's. Now coming back, fistula, strictures, fibrosis, all these are more common in Crohn's. So here, fibrotic strictures, these are common. Fibrotic strictures are common. But in ulcerative colitis, fibrotic strictures, these are rare. And you know, toxic megacolon is more common in ulcerative colitis. So toxic megacolon, it is common in ulcerative colitis, but Toxic megacolon, it is rare in Crohn's disease. Rare in Crohn's disease. There are certain named signs which are asked frequently in relation to Crohn's and ulcerative colitis. So first see the named signs of Crohn's disease. So there is string sign of Cantor. Why? Because there is long stricture of terminal ileum. There is hose pipe appearance. So string sign of Cantor, hose pipe appearance. There is creeping fat sign which is characteristic feature of Crohn's disease. Cobblestone appearance because in between there is normal mucosa and then there are involved areas. So this is cobblestone appearance. Comb sign, there is vascular jejunization of ileum, that is comb sign. Raspberry thorn or rose thorn appearance, there are linear transmural ulcers or fissure. This leads to raspberry thorn or rose thorn appearance. And fat halo sign, what is this? There is presence of low submucosal, low attenuation submucosal fat around the bowel. So low attenuation of submucosal fat around the bowel, that is fat halo sign. So how to remember? The mnemonic is string has CRF. How to remember here? For Crohn's disease, the mnemonic is string has CRF. So string, sign of Cantor. H means hose pipe appearance. C means creeping fat sign. Cobblestone, comb sign. R means raspberry thorn or rose thorn appearance. And F, that is fat halo sign. So string has CRF. What are the named features of ulcerative colitis? You know that in ulcerative colitis, especially in chronic cases, there is ahostral colon. And that ahostral colon, it is also known as lead pipe sign. Other name is pipe stem colon. Other name is garden hose appearance. And other name is stovepipe appearance. So all these are the names for ahostral colon. Lead pipe sign, pipe stem colon, garden hose appearance and stovepipe appearance. And in ulcerative colitis, there are collar button ulcers. These are actually deep ulcers. So how to remember? LPG, stove, collar button. Mnemonic is LPG, stove. This is LPG, stove, collar button. So this is LPG, stove, collar button. Clear? So lead pipe sign, pipe stem colon, garden hose appearance, stovepipe appearance, and collar button ulcer. These are seen in ulcerative colitis. So these were the important points related to inflammatory bowel disease.